Welcome to this explainer. You know, if you're a medical coder, reviewing charts can honestly feel like navigating a maze sometimes. But today we're going to completely clear that path. Think of this as an absolutely crucial chart review session. We're going to master the strict pregnancy guidelines found in ICD-10-CM Chapter 15 together. Whether you're dealing with a standard gestational timeline or jumping into some really complex, high-risk scenarios, getting these codes exactly right is literally the bedrock of proper patient care and, of course, facility reimbursement. Okay, let's dive into this.
Here's our roadmap for today. 1. Navigating complexity. 2. Tracking trimesters. 3. High-risk status. 4. The O09 breakdown. And 5. Codes in practice.
Section 1. Navigating complexity. The vital role of accurate pregnancy coding.
Well, we all know pregnancy is an amazing and exciting time, right? But medically and administratively, it is incredibly complex. Pregnant mothers and their clinicians can have a multitude of conditions to contend with, and some of these are far more critical than others. This is exactly why your job is so incredibly important. Because of all the possible scenarios that can pop up during a pregnancy, reporting your ICD-10-CM diagnosis codes must vividly and accurately reveal the specific risks a patient carries. It's like building a giant puzzle. The specificity of your code is what guarantees that the mother and the clinician actually have the right resources, procedures, and treatments approved and ready to go when they need the most important.
Section 2. Tracking trimesters. Building the baseline timeline.
Now, what's really interesting about this slide is how ICD-10-CM Chapter 15 creates a very strict, standardized timeline for all patients, and that's regardless of whether they're considered high risk or not. The clock starts ticking on the first day of the woman's last menstrual period, so the first trimester is anything less than 14 weeks, 0 days. The second trimester spans from 14 weeks, 0 days up to less than 28 weeks, 0 days, and the third trimester takes us from 28 weeks, 0 days all the way to delivery. As a coder, your first listed or principal diagnosis code always identifies exactly where in this gestational period the patient is during their current encounter. Every single one of these codes includes a specific character, usually the fifth or sixth one, to denote this exact trimester. For instance, if you spot a code like O09.513, that little 3 at the very end tells us for sure we're in the third trimester.
On top of the trimester, the beginning of Chapter 15 actually directs us to use an additional code to pinpoint the exact week of pregnancy, assuming it's known. That's where category Z3A comes into play. It uses the fourth and fifth characters to state the specific week of the gestational period. So it starts down at Z3A.01, representing less than 8 weeks of gestation, and it goes all the way up to Z3A.49 for anything greater than 42 weeks. You just tack this on as an additional code alongside your primary one. Capturing this precise week-by-week detail is absolutely vital, and not just for the immediate continuity of care between providers, but also for driving ongoing medical research.
Section 3. High-risk status. Why extra details matter. Okay, once we have our baseline timeline locked in, we have to stay on high alert for complications, situations that demand specialized services. A patient determined to be in a high-risk pregnancy logically requires a lot more attention than someone having a routine gestational period. And this brings us to a foundational rule of medical documentation. The obstetrician must not only document the high-risk status, but stipulate the specific reason for this determination. I really want you to let that sink in. A provider simply scribbling high risk on a chart? Yeah, that just doesn't cut it. Abstracting the specific reason from the chart, the actual why behind the risk, is the core job of the medical coding professional.
To accurately code that specific reason, we rely on category O09, which stands for the supervision of high-risk pregnancy. We reference this category for a current pregnancy where there's a present or past condition that flags it as high risk. So the crucial point is that this category is our primary tool. It's what actually directs the level and frequency of clinical and inpatient facility care the mother is going to receive.
Section 4. The O09 breakdown. Chunking the subcategories.
Because O09 is so critical to get right, let's meticulously break down its 15 subcategories. We'll start with reproductive history. O9.0 is used when there's a history of infertility. Next, O9.1 captures a history of an ectopic pregnancy. If there's a history of preterm labor, you're going to look for O9.21. We use O9.29 for other poor obstetric history. And finally, O9.A is applied for a history of a molar pregnancy, which is a rare complication where a non-viable fertilized egg implants. And just a quick reminder,
Notice how the dash at the end of all these codes is just waiting for you to plug in your specific trimester character.
Moving right along to our second table, we group together maternal age, parity, and care. O09.61 and O09.62 denote a young primigravida, meaning it's a first-time pregnancy, or a young multigravida, meaning she's been pregnant before. On the flip side of that, O09.51 and O09.52 capture the elderly primigravida and elderly multigravida, which typically refers to mothers over age 35. If the chart indicates there has been insufficient antenatal care, you'll report O09.3. And O09.4 indicates grand multiparity, and that's used when a woman has had 5 or more previous births.
We wrap up the breakdown with our third table, highlighting some of the diverse social and procedural nuances that can complicate a pregnancy. O9.7 is for the supervision of a high-risk pregnancy due to social problems. O9.81 is vital when the pregnancy results from assisted reproductive technology. O9.82 denotes a history of an in utero procedure during a previous pregnancy, and then we have O9.89 acting as a catch-all for other high-risk pregnancies not specified anywhere else. Just looking over this list, you can clearly see the incredible level of detail required when abstracting from the documentation. It's the only way to ensure the patient gets the right oversight.
Section 5, Codes in Practice, a real-world chart review. Let's move to and see how this builds into an actual clinical scenario you might encounter on your shift today.
Imagine you're reviewing a chart right now for a pregnant woman who has a documented history of ectopic pregnancies. You correctly pulled the subcategory O09.1. But let's pause and look at the clinical context of why this specific code really matters. An ectopic pregnancy is a highly dangerous situation where the zygote, the fertilized egg, implants completely outside of the uterus, very often in a fallopian tube. Because of this history, pulling the code O09.1 instantly justifies to the insurance provider the urgent medical need for early ultrasound exams and much more frequent obstetrician visits. We need to make absolutely sure the current egg has implanted safely.
To put that into perspective, ectopic pregnancies occur in just 1 to 2% of all pregnancies in the United States. But make no mistake, it is a sudden, life-threatening condition. This really hammers home the incredibly high stakes of accurate coding. I mean, your keystrokes are directly facilitating the preventative care that could quite literally save a mother's life.
And this brilliantly illustrates a vital distinction you absolutely must master. Subcategory O09.1 denotes a history of an ectopic pregnancy during a current, otherwise standard pregnancy. Conversely, category O00 denotes a current, actively occurring ectopic pregnancy. You must never ever confuse a history of a condition, our O09 codes, with a currently active complication falling under O00. Mixing these two up completely changes the clinical picture, the treatment plan, and of course, the facility reimbursement.
So, as we wrap up this explainer, I want to leave you with a really vital question to consider before your next shift. Are your chart reviews accurately capturing the difference between a high-risk history and a current complication to ensure proper reimbursement and patient care? Remember to strictly track those trimesters, always dig for the specific reasons behind a high-risk status, and always double-check those O9 subcategories. Accurate coding isn't just about administration, right? It's the bedrock of quality maternal care. Keep up the great work, stay hyper-focused on those guidelines, and I will see you in the next one.